So you don't feel well. You're achy. You're not sleeping well. You're anxious. You're depressed. You've gained weight. Your hair and skin have changed. Pretty much everything has changed. And you go to the doctor and you say to the doctor, can you just test me for everything? Because I just don't feel well. I don't feel right. I don't have the energy I used to have. I don't feel like myself. So the doctor runs the tests and you get the results and you're told, your testing's normal. You're fine. You're put on this line of fine. And you know you're not fine. And you know you're not normal. And you know this isn't what it's supposed to be. But you don't know what to do. And your doctor told you you're fine. I brought the solution for you today. So, today I have Dr. Carrie Jones. This is the queen of hormones, but I actually refer to her as the queen of functional testing. She has been the clinical director of Rupa Health, which is kind of the marketplace of all functional testing. And she has spent her career looking deep, looking at what labs to order, at what these labs tell us, and she is this amazing investigator helping women to get their ideal health. And if you don't know the questions to ask, this is where you need to be right now. Because not that you should be your own doctor and not that you are expected to be your own doctor, but it is so important in your journey for you to know the questions, know what you should be asking for, know the values that you should be looking for so that you can be an active participant in your health because it's so important. So sit tight, get ready, get something to write with, get comfortable because here comes Dr. Carrie Jones. Okay, so I just want to start with so many women are told that their labs are normal, right? They get put in that line of fine. And so they go to see their doctor and they know they don't feel well. They know they don't feel right, but they're told their labs are normal. So what does the queen of labs have to say about that?
Oh my goodness. First of all, it's so frustrating. It's so frustrating. And I've been there myself. I've have a primary care and get labs drawn and I get this email back in the portal that's like, congratulations, you're normal. It's all fine. And I'm looking at it like, no, it's not. It's the whole reason I went to see my primary care. But what's frustrating, I find, is that women often go, I don't feel good. I'm tired, or I feel hormonal, or my periods suck, or my hair's falling out. And so they'll go, I would like comprehensive testing, or women know enough to say, test everything, figure out
Yes,
what's
they
wrong,
you're
right?
exactly
Like,
right. They do say test everything. But
yes.
unfortunately, the person that they're asking to test everything has no idea what that means.
And what comes back, it always shocks me. They'll say, okay, I tested everything. Your hormones are fine. And then I get a hold of it or you get a hold of it. What is it? It's a complete blood count, which is red and
Yeah.
white blood cells.
Yes.
Okay. You get a metabolic
Platelets. Don't
panel,
forget about platelets.
platelets, right? You get a metabolic panel, which, is fine. Got some glucose in there, your electrolytes, calcium, some liver markers. Okay, cool. Maybe,
Okay, but
maybe
it doesn't
you get a
include an
TSH.
insulin, which I don't
No,
understand
no.
why.
Yeah. Some an, an A1C, like something extra. And then maybe if you're lucky, you'll get a TSH, thyroid stimulating hormone.
Hmm.
And that's about it. And then they'll
Alone.
come back and tell you in your portal, or the nurse will call you and say, your labs are great. Your labs look fine. Well, of
Yeah.
course they do. My red and white blood cells are not the problem. That's not what I'm worried about. I'm not worried about my liver enzymes. I'm not worried about my electrolytes. Those aren't what's causing me to be exhausted and rageful and my periods and my hair and my skin. That's not the issue.
Yeah.
So,
And not for nothing, but um when when people get that and they know that it has nothing to it, they know that they weren't covered,
yeah,
right? They know.
yeah, absolutely. Yeah, I'll actually, I'd say yes, a lot of women know. And then some women will go, I will ask, have you had lab work yet recently? And they will go, oh yeah, I got a full workup. My hormones are fine, but that's not what it is. So because they've been told everything's fine, they've been told they had a comprehensive workup. Like, you believe it. Why wouldn't you believe it? You
Yeah.
don't want you to think your practitioner's lying to you. Not that they're lying. It's just their comprehensive and our comprehensive are very different. Their idea of
Yes.
a full workup and our idea of a full workup is very different.
Yes. But they
And so,
also know that they're not fine. Despite the fact that their labs are normal, they know that they're not fine.
right. How could you deny it? If somebody comes in and they're listing all their symptoms, as a doctor, immediately I'm like, oof, this poor
Mhm.
person, they
Mhm.
feel terrible. They're checking all the boxes. I know. The nurse knows, the medical assistant knows, the front desk knows, like everyone knows.
Yeah. Yeah.
But it's so
Well,
frustrating.
the doctors don't know. That's
Yeah.
what's so sad is that we're so, and I came from that conventional medical system.
Mhm.
I came from there. So I'm so, I understand where they're coming from because that's what we were taught.
Yeah.
That's literally what we were taught to do. And we have so little understanding about how to evaluate someone outside of your little tiny silo that you were trained in.
Yeah. I had to go see my primary care was unavailable, and I saw her physician's assistant, who was the nicest man. And he said, "What do you do for a living as a naturopathic doctor?" And I said, "Hormones. I'm in hormones and women's health." And he literally sat back on his stool and he said, "Oof, I don't do hormones. I refer them on." I said, "Not at all. You don't even like do a cursory workup?" He said, "No, that's not what I do." Now, kudos to him for knowing his boundaries and
Mm-hmm.
knowing he cannot and does not understand it and do it. But also I thought, man, I bet a lot of practitioners feel that way in their head. They don't know what to do. They don't know what to
Well,
order. And they
yeah,
either do nothing or they refer them on.
yeah, that's totally true. And yet, the people that we rely on for hormones are either the endocrinologists, which I'll tell you, they don't know either. I mean, the
Mhm.
endocrinologists are guilty of that TSH alone too.
Right.
They're not ordering full thyroid panels. They're maybe ordering a free T4, maybe,
Maybe.
maybe,
It's reflex.
yeah. But most of them are still ordering a TSH alone, and they are not female hormone experts, and they don't even get involved,
Yeah.
right?
Yeah.
So the people who are supposed to be the hormone experts, the endocrinologists, are not hormone experts. And then we go to our gynecologists, who unfortunately are also not hormone experts. They are used as hormone experts, but they're not trained as hormone experts. And so what ends up happening is they either do nothing or complicate the problem more.
Mhm.
So what happens is when you train to be an OBGYN, this is a surgical specialty. It really is. It's
Yeah.
not a medical specialty. So they are not really getting trained on how to evaluate female hormones. They're mostly getting trained on delivering babies, which is very important. It's
Very.
very important to know how to do that safely and properly. And they're getting trained to be gynecological surgeons. They're getting trained on how to remove tubes and ovaries and uteri safely, right? That's really what the bulk of their training is. So, what happens when someone comes to them with a hormone abnormality? They put them on birth control pills
Yeah.
because that's the only thing they were trained to do.
Yeah.
Or if you're bleeding too much, they put you on progesterone. So band aid, band aid, band aid, band aid, band aid. Meanwhile, this person has significant hormonal dysfunction that is not being fixed by putting them on oral contraceptives or by progesterone to stop bleeding. It's not fixing the problem.
Right.
So we rely on people that are totally untrained to do this very important job, right?
Yeah.
So what
Yes.
do you think what should we be doing? What should people be doing?
One, arm yourself with education. That's why you're listening to this podcast, because you have a pen and paper out or your notes open in your phone and you're writing down the lab work we're going to talk about that you should ask for. And two, now that you're educated, once you get to the end of this episode, you're going to, when you go in and ask for a full workup or comprehensive workup, you can present with a list.
Yeah.
Here are the things I would actually like to have tested and the reasons why. This is why I feel like it's important. And
Yeah.
I want to preface this by saying we're not requesting wild, crazy, rare, hyper expensive testing.
No.
You mentioned an insulin. I mean, an insulin, I fully agree, should be a first line test to go, especially with glucose, when we're looking this up, we're
Yeah.
working this up.
Yeah.
When we're looking at thyroid, I absolutely don't think it's wild and crazy to not only do a TSH, thyroid stimulating hormone, and a free T4, and what's called a free T3. Some insurance groups will straight up not cover a free T3. They think it's excessive. And I just think you don't understand physiology. You
Mm-mm.
don't understand that the majority of your T3 creation is out in your cells. It's not in the thyroid itself. And oh, by the way, the amount of T3 you have doing the work out in your cells doesn't necessarily communicate back to your thyroid. So, or even your brain to impact TSH and then T4. So you can have two totally different thyroid conversations happening. The one in your brain, what's coming out of your thyroid, and out in your cells. So there's three. And if you don't understand that physiology, okay. But insurance companies who are like, well, we just don't cover free T3. Like, we don't think it's necessary. Like that's the heavy lifter. That's the power horse out in the
Yeah.
cells
That's the
doing the
active
thing.
form.
That's the active form. Like
Yeah.
free T3 is what makes a lot of cells go round. Like, come on now. TSH is not what does it. That's just a signal communicator that's impacted by so many things. And it's often right in the range you want it to be. It's kind of like sitting pretty coming out of the brain. It's doing
Yeah.
fine. And that's what frustrates me so much. And so when we ask, I definitely have had doctors say like, ooh, no, we can't run a free T3. I'm like, why not? Then let me pay out of pocket. It's not that expensive. Just add it on. It's like an insulin. Just add it on.
Yeah. It's very
It-
frustrating. And also, so you're coming from this super duper educated place, but most people don't even know the questions to ask. Most doctors don't even know the questions
right.
to ask, as it
Yeah.
turns out. So I know you're the queen of functional testing, and we are going to get to all of that because I'm not going to waste my opportunity here with the queen. But I do think that you can get a lot of information before even going to functional testing, right?
Absolutely.
A lot of
Absolutely.
information. So I want to
Absolutely.
hear what's on your doc. I don't feel well. I'm exhausted. My skin is dry. My hair is dry. I'm losing my hair is thinning. I'm
Yeah.
losing the outer third of my eyebrow. I've gained weight. I just don't have the energy that I had before. I don't have the mood that I had before. I don't have the libido that I had before. I just don't feel like myself or recognize myself. I know you're not saying to them, "Oh, you're getting older.
Yeah. Oh,
This is this is
you have
normal."
kids. This is what happens
Yeah.
when your kids are that age.
Yeah.
Yeah.
Yeah. Yeah. Or you're busy
Yeah.
or right? Because busyness doesn't cause your eyebrow hair to fall
It
out.
surely
Busyness
doesn't.
doesn't cause dry skin, thank God, or
Yeah.
I would have a lot of issues.
Right.
Um, so what should this initial lab investigation look like for the person that knows they're just not they just don't feel right.
Yes.
They're not fine.
Yes. Okay. Here we go. I made fun of the red and white blood cell count earlier. It's called a CBC, complete blood count. We still need to run it. It's still important. I need to know if you're anemic. I need to know if you're fighting some sort of infection. There's something wrong with your platelets. So I do run a CBC. I do run a metabolic panel. I want the glucose in there. I do look at your liver enzymes. I look at everything. I'm thorough. I am comprehensive. So CBC and what's called a CMP, comprehensive metabolic panel. Then I run your thyroid panel, TSH, free T3, free T4. I run both of them. And then if you haven't had it done in a while, and especially if you have all those symptoms you just said, dry skin, outer third of your eyebrows missing, hair loss, weight gain, constipation, I'm running your thyroid antibodies also. So we have the main one is TPO, thyroid peroxidase antibody. Thyroglobulin antibody, TGAB, is the other one, the other main one. Because if you're positive, that means you have an autoimmune thyroid issue going on. And sometimes those are positive before your thyroid labs are problematic. So I know it's coming, it's building, and we need to do something about it. Depending on your symptoms, I will also run an iron panel. I may just run iron and ferritin as a cursory, as a screener. But if you have a history, heavy periods, bruising easily, I will run a full thyroid panel and see what's going on. I will run a vitamin D because, well, I live in the Pacific Northwest. We don't get sun. So I need to
Yeah,
see what
but
my D is
I do
doing.
want to say something about that, right? Because I had David Letourneau on my podcast not too long ago. I don't know if you know David, but
Mm-mm.
David invented the energy light, the vitamin D light.
Oh, yeah.
And he lives in Scottsdale and he exercises outside every single day with his shirt off. He's like one of those RFK
RFK.
buff, RFK like 60 something, 70 something. I don't know how old he is and I don't want him to get mad at me. But he's one of those very fit, healthy, silver haired
Yeah.
guys, right? Who exercises outside in Scottsdale every single day. So he goes to have his vitamin D measured, thinking, like, there's no way I'm going to be vitamin D deficient. Guess what?
Oh, no.
Vitamin D deficient.
Oh,
Because
no.
even if you are in the sunshine in your shorts every day and you live in Phoenix, you actually need exposure to UVB light.
Mm.
And UVB is only a fraction of sunlight, and you have to get it at the exact time of the day, which is midday sun when the sun is like directly above you at the strongest time, which is when most people in Scottsdale, incidentally, are not out there because it's like
Yeah.
unbearable.
Yeah. Fair.
And so, even if you are living in this ideal climate, it doesn't mean that you're going to have ideal levels of vitamin D. And then there are people like you and I who live in very unideal climates. And my vitamin D, if I'm not supplementing, but I'm getting a light. But my vitamin D, if I'm not supplementing, is abysmal. I
Yeah.
live in Philadelphia. We're
Yeah.
hiding most of the year.
Yeah.
Like, even when it's beautiful, it's 31 degrees outside today. You think I'm taking my clothes off? You got another thing coming.
That, and when you and I go to ideal climates, I was just in Palm Springs last week where it was 80 and sunny. I am the color of a cell phone flashlight. Like, I was designed to woman Viking ships and train dragons, you know?
Yes.
So I'm covered in zinc oxide, at least part of it, because I don't exactly, my melanin doesn't agree with the sun. And I have a very long history of basal cell, unfortunately. And so I get sun. I definitely do. But I burn very easily and I have to be very careful. So even
Yeah.
when I am in the sun, it's not for long periods of time. It's usually under an umbrella. I have to be careful. And I
Yeah.
don't get the vitamin D.
Yeah. So sunshine is very important, right?
Yes.
And it's important for our eyes because that is the signal to our brain to actually release antioxidants into the skin and to tie us with circadian rhythm, which is important for sleep and all kinds of processes in our body. So I am not telling anyone to avoid the sun, but I'm telling you that the likelihood that the sun alone can provide you with the vitamin D level that you need in this day and age is nearly zero.
Not great. Not great, which is why I test it. Let's see what's going on. I do also often test a vitamin B12 because oddly enough, I have found it low a number of times in people, and B12 is an easy fix. And low B12, mental, neurological energy, B12 does a lot of things in the body. So I check a
Yeah.
B12.
Yeah.
Depending on your age, while this doesn't necessarily contribute to the fatigue and everything, if you are especially 40 and over, headed in that direction with hormones, I do immediately start looking at your lipids. So I do what's called an advanced lipid panel. Which is your cholesterol, is what I mean. Talk about your cholesterol, triglycerides. I will look at something called an apolipoprotein B. Depending on your symptoms, if we have a lot of inflammation going on, I will do what's called an HSCRP, high sensitive C-reactive protein. And I may add on other lipids panel information depending on your family history, your personal history, what's going on. But we're talking some screening stuff. Then I can run hormones. You can do hormones in the blood work. And what frustrates me more than anything is when I hear back from people who say, Oh, I don't test women's hormones because they change a little bit every day. Like, I know. So let's time it appropriately for where they are in their cycle, or then if they're postmenopausal, they can test anytime. You can
Yeah.
absolutely run a progesterone, an estradiol, a testosterone, a total testosterone, a free testosterone. You can run a DHEAS. S stands for sulfate in the blood work. I can do a morning cortisol on you. It's not the best marker for cortisol. We have way better markers out there. But if I have to start somewhere, maybe, budget is a huge thing. I can use it as a screener. I'll do a morning
Hmm.
cortisol on you.
I
All
I
of that can
I
be done in
almost
blood work.
universally do a morning cortisol, and
Yeah.
it's a pretty good indicator of who is walking around white knuckling life.
Yes. Oh my
I'll tell
gosh.
you that I can it is a very good indicator of who's walking around white knuckling life. You
Yes.
may not pick up everyone, but it's pretty good.
Yeah. Yeah. I agree completely. And it at least gives me an idea of do we need to do more advanced testing? Do I look at this harder?
Yeah.
Or am I referring you for some pretty significant nervous system help for that? And then of course insulin. We've mentioned it a few times. Insulin, I think, is a huge, especially that I can't lose weight. I'm hungry all the time, or I'm hungry after meals. I'm constantly craving sugar. History or current of PCOS, definitely I think insulin should be standard. The issue with insulin, which I know you agree and talk about, the reference range is much too large for insulin. So even if somebody does manage to get an insulin done, the reference range is often up to 20 or 25.
Yeah.
So like
Yeah.
2 to 25, 2 to 28. And
Yeah,
you'll be
what could be
21,
wrong with a circulating
22.
insulin of 20?
Oh my
What could be
gosh.
wrong?
But it's in reference range.
I
I was
know.
reading this article that said if it was talking about high insulin, higher levels of insulin, and it said if you have higher levels of insulin, you have a 3x chance of developing metabolic syndrome. And I thought, gosh, high insulin. I wonder what the authors think high insulin is. It must be over 20, 25, 30, 50. And it was something like over 6.8, over 7.2. I was like, what? Why is the research not caught up with our reference ranges? Why are we giving this huge grace period when we should be catching people much sooner when they develop high insulin resistance? I mean, that's a big
Well
problem.
well, you know the answer to that
I do
question.
know the answer. It's
Yeah.
rhetorical, but still,
So,
it's so frustrating.
unfortunately, the way that our system is set up, doctors cannot make money unless you're sick.
Yeah.
Hospitals cannot make money unless you're sick. Pharmaceutical companies who control the narrative and control medical education cannot make money unless you're sick. So the system is set up to promote failure, right? And so
And it
we
does.
have these enormous reference ranges that literally include 95% of the population. Now, do you want to be within at the same range that 95% of the population is? Because I know I don't, right?
And
Like,
especially because we know a lot of the population is sadly, unfortunately, very unhealthy.
yes, yes, of course. So I think the statistics now are that over 90% of Americans have metabolic dysfunction.
I just read
Over
that. Yeah.
90%. This is frightening. I
Mhm.
don't want to be part of that 90%. I want to be exceptional, right? I
Yes.
want to set the standard for what is ideal, what is optimal. And that's what we're never talking about. We're never talking about optimal ranges. So even if all your doctor does are those precursory labs that we talked about in the beginning, and we said, oh, well, they're normal, even that is not normal,
Right. And
right?
what are we waiting for if you're borderline? So a blood sugar, a glucose above 100, but so 100 to 125 is considered pre-diabetic. So let's say you're listening to this, you've got your lab
And
work
you're
out,
talking about a fasting
a
glucose now.
fasting glucose. You went in
Yeah.
the morning to the lab fasting. 100 to 125 is considered pre-diabetic. You look at your own lab work right now today, listening to this, and you're at 99. Why would you wait
Right. Are you
to get
okay?
over 100 to do something about it? What
I
if you're
can't.
125? What if somebody says to you, you're fine, you're normal. Your blood sugar is a little higher than we like. So, work on that. You're 125, 126 and over on a fasting blood sugar is considered diabetic. Why are we waiting? Why are we not intervening? Why are we not being proactive? I mean, again, rhetorical question, But this is what's so frustrating, because you get the phone call, you get the portal email that says, you're fine, you're in range, or you're a little up. So we'll check it again in a year. Keep an eye on it. What? You don't feel well. This is contributing to it. You don't want to be borderline or at the
No,
line. We want to
no,
pull you back from the cliff before you fall off.
I know. But they want you to qualify for the drug. And that's what's going on there.
And
That's what's
then
going on there.
a lot of people start one, which leads to two, which leads to three. By the time you're 50, 60 years old and you're on multiple medications, cholesterol, mood, blood pressure, blood sugar, et cetera, et cetera, et cetera. It's not fair. It's not fair to the people, because we look at it from the other lens of like, gosh, there's a lot we can do before we even get that, before you fall off the cliff into pharmaceuticals. I'm not against pharmaceuticals at all, but I am against essentially kind of pushing people over the cliff into them when we could have done a lot of prevention before.
Well, there are some pharmaceuticals that I'm against.
Okay, well, yeah,
So
fair.
I want I want to go back to you started to talk about you get an advanced lipid panel, and you talked about the things that they're named there. And I think that there's something that's worth calling out, because we're using that cholesterol as a catch-all, right? And
Yeah.
people have in their head that if you have cholesterol above 200, that you should be on a cholesterol medication. So I want to dive into this a little bit, because according to Dr. Jen Simmons, I think this is all about a statin narrative,
Mm.
right? This is about how to get people on statins. So I want to talk a little bit about what you are looking for on that lipid panel, and then what you think of statins and this whole cholesterol story, because the cholesterol story ends up being very important in the hormone story.
Huge.
And we know what happens to people when they go on statins.
Yeah.
So I would love you to talk about that, talk about triglycerides, talk about HDL, talk about what the importance of those are.
So with cholesterol, obviously we have different types of cholesterol. And as a very dear friend, a longevity expert, explained to me, think of cholesterol like a bouncy ball in your arteries. It's bouncing along. And what you don't want it to do is bounce so hard against the wall that it sticks. And if it sticks and makes its way through to the other side and it gets inflamed and the immune system comes, this is the progression of plaque. So we have soft plaque initially because you have a soft bouncy ball. And then eventually it can become a calcified plaque. And the calcified plaque can grow. And this is where your arteries narrow, and it can put you at risk for a heart event, stroke if it's in the brain, heart attack if it's, below the brain. Then we have a problem. Houston, we have a problem. So when we're looking at cholesterol, I'm looking at everything from how many bouncy balls do you have? And there is some people may have heard of a marker. It's called an LP little a. And as it was described to me, it's like those sticky hands that we were played with kids. We'd like throw the hand against the wall and it would stick and it was gross and gummy. So the LP little a is like a sticky hand wrapped around the bouncy ball. And the more you have, the more sticky it is to the wall. So now again, more balls against the wall, like the rap song, we've got problems. So we've got plaque formation and eventually calcified plaque formation. So we can test this. I can test LDL. I can test LDL particle. I can test LP little a. I can test inflammation. And because we know more than 90% of people have metabolic dysfunction, which includes a lot of these markers, inflammation, cholesterol, et cetera, my vision is long-term goal to prevent the cardiometabolic event. I'm trying to reduce your risk for stroke. Same for any kind of heart attack. And we know heart disease, cardiovascular disease, is the number one killer of humans, men and women. So when I'm looking at cholesterol, especially, we're going to stick to women, especially as women go through the perimenopausal transition, oftentimes that decline in estrogen increases and changes for the worse all of their lipid panel results. So you'll have women, you may be listening to this right now and think, I've always had low cholesterol. Carrie, Jen, I've always had low cholesterol. And then I turned 45, then I turned 50, then I went through menopause. And my blood pressure went up, my glucose went up, my lipids went up, everything went to heck in a handbasket. And estrogen plays a big role in how we use, get rid of, function with cholesterol. Now, the other interesting part of cholesterol is that some people genetically make a lot of cholesterol. They're great makers. They're great. Their little factories for cholesterol are turned up really high. And other people are really good at recycling cholesterol. So as cholesterol gets ready to get excreted from the body, it goes through the bile, and then the bile goes through into the intestines, and essentially you poop it out, believe it or not. So you have little grabbers in your intestine that can grab the cholesterol back and pull it back in. Like you thought you were out, and it pulls you back in again. And now you have more cholesterol floating around. And I can test for that too. I can test to see, are you a factory maker? And I can test to see if you're a recycler. Are you pulling it back in? And this information can help with treatment ideas on in which way we go. Because statins don't impact all of this. It doesn't help inflammation. It doesn't really help recycling. It doesn't help so much the LP little a. I mean, sort of. It like raises the LP little a, but it lowers the ball count. So there's there's arguments pro and con against. So when I'm looking at this, it's a bigger conversation, and it's a lot more lab work than you think. Than just like, oh, what's your total cholesterol? Over 200. Okay, let's do something about it.
Yeah.
What if
But
it's
there are
pure
still
inflammation?
so many doctors that, like, my husband's concierge doctor gave him his list of labs for the year, right?
Mhm,
And I
mhm.
called him and I said, "You need to add on an HSCRP." And he said, "Why?"
Oh,
And I'm like,
I mean,
"Really?
why?
Really?" And they don't know that, high LDL alone, in the absence of an elevated CRP, is not an independent risk factor of heart disease.
Right.
Like, they have to be together. He didn't know that.
Which
It's
is
just not,
not uncommon. Yeah,
it's
sadly.
crazy to me that these people that are in charge of people's general health and wellness, they don't know.
Right. Right. And if they don't know, how is everyone listening supposed to know?
I know.
How is the
I know.
general public supposed to understand it?
I know.
It's the same with just hormones, If the majority of practitioners don't know, other than here's the birth control pill or here's the Mirena IUD, then how is everybody else supposed to know?
Yeah. No, it's so true. And I think about, so the other part of the cholesterol story that we're not talking about enough is that cholesterol is a very, very, very important molecule, right? This is the
Very.
base
Yes.
molecule for our hormones. This is the base molecule for our neurotransmitters. And you cannot be healthy without healthy levels of cholesterol. And when we put people on statins and just lower cholesterol, lower the LDL, which is the building block of our steroid hormones, we are not serving people, and we're actually decreasing their metabolic health. And people who go on statins have a 63% increase in diabetes. This is a problem,
And
and that we're not talking about.
these are the conversations. I see this a lot more, quite honestly, in men. So when I was in practice full time, I had a small handful of men, often husbands of wives, who were like, just go see Carrie, even though
Mhm.
she's women's health, like go
Yeah.
see her. And they would be on very large doses of statins for whatever reason, and their cholesterol would be very, very low. So if the range is up to 200, they'd be at 100. They'd be at 110 for a total cholesterol.
Yeah.
And as a result, their testosterone was super low. They felt a lot of brain fog. They felt fatigued. They felt all the things, right? Erectile dysfunction. So these were always the conversations I would have with their cardiologist. I would call and say, hey, I get you want their cholesterol, their bouncy balls to be super low because you're worried about heart event, maybe their history, family history, whatever it is. However, their daily living sucks. He's tired all the time. He has brain fog. He's gaining weight. He can't get an erection. He's feeling pretty depressed. Can we negotiate this? Because it is literally the LDL droplet LDL being the cholesterol, a droplet, as you said, is the backbone to all our steroid hormones. So testosterone, progesterone, estrogen, cortisol. And cardiologists are thinking one thing, don't die of a heart attack. And that's great. However, I want them to enjoy the rest of their life.
Yeah.
So I'm always negotiating. So how can we I need them to feel better, but like not die of a heart attack at the same time.
Yeah. Well, also, not for nothing, but cholesterol is not really part of the heart attack story, in that when you evaluate these people that turn up in the ER with an active MI, a myocardial infarction, a heart attack, 50% of them have normal cholesterol.
Which is wild. Think of the sports, right? We've all heard of the high schooler who sadly, or the college student, or the football player, the NFL, or whatever. They're at training camp and sadly, had a heart attack and had allegedly perfectly normal levels of cholesterol.
Before we leave this, I just want to hear what you use as a metabolic screen to know about metabolic health, because we were just at A4M, the American
Mhm.
Academy of Anti-Aging Medicine. The entire focus of this past conference was metabolic health. And what my talk was about was that metabolic health is and loss of metabolic health. This
Yeah.
is a major precursor to breast cancer. And
Yeah.
if we would screen for metabolic health with the same vigor that we screen for breast cancer, and we worked collectively to improve metabolic health, breast cancer would be reduced significantly. Like
Right.
80% of breast cancers are preventable. 80%.
Right. Right. It's
So,
wild.
what do you use to evaluate people's metabolic health?
So I look at glucose, insulin, triglycerides. Triglycerides are often in the lipid panel, your cholesterol panel. They are part of metabolic health. I will do a hemoglobin A1C as part of the lab screening. If we can do so, I do a CGM, a continuous glucose monitor, because I can use the lab work for that particular day, what's going on, but I can use the CGM as more over, depending how often we use it, over 2 weeks. They're good for about 10 to 14 days. So I may have them do it a month. Like, let's get a full month and see what's going on. Combining that in is what my screening is for metabolic health. I know there are other markers out there, but at the minimum, we talked about this earlier. At the minimum, if we can get someone to do add an insulin to their fasting blood work, oh my gosh, that gives us so much information right off the bat. How about you?
Yeah, I do the same thing. And then I'm also making sure that we're measuring blood pressure, that we're measuring
Totally.
waist to hip circumference, because we know that visceral fat, that fat that's around the abdomen, we know that that is a risk factor in and of itself
Yeah.
for metabolic disease. Now, there are going to be some women who are straighter
Okay.
or who have a lot of muscle mass. And so maybe their waist to hip ratio looks more like a man's.
Mhm.
But if you're that muscly person, right?
Yeah.
As opposed to the woman who is straight because she's carrying a lot of weight around the middle. And so her middle matches her bottom,
Mhm.
right? Because we're
Yes.
supposed to have a waist to hip ratio of 0.8, meaning that your waist is 20 times 20 no 20%, sorry,
Percent. Yeah. I was like,
20%
percent.
smaller than your hips. So I include that, and then I do all the other labs that you talked about.
You know what's
um,
interesting? I don't know if you've read this also. I was reading about the concept, and it needs more study, of testosterone to estradiol in women. So these authors were saying, as women go through the menopausal transition and they get the belly fat, they turn into an apple shape as opposed to a pear shape. One of the contributing reasons, there are several, one of them is there's a relative decline of estradiol faster to testosterone. Not every woman loses testosterone as she goes through menopause. Some have still amazing levels. but estradiol declines faster. And so now the body says, oh no, that's a lot more androgen hormone, testosterone, compared to estrogen. And women's androgen hormones receptors tend to be in the midsection, in the middle body. If you think, for those of you who are aware of or maybe have PCOS, polycystic ovary syndrome, they tend to be, again, that androgen dominant. They tend to gain weight in the middle. They tend to
Yeah.
have the apple shape.
Yeah.
That testosterone estrogen discrepancy, with testosterone kind of winning relative to estrogen, increases visceral fat, not subcutaneous fat. These authors I was reading were like, it's very androgen receptor dominant visceral fat, which is inflammatory and increases more weight gain and more risk for metabolic syndrome. So now what I've been looking at is when these women going through perimenopause or very early menopause, is I'm gauging how far is your testosterone dropping relative to your estrogens, who's winning, and what's your body shape looking like. It's the
Yeah.
same I would do with PCOS women, androgenic women,
Yeah.
but you may have gone your whole life normal weight, let's call it, typical weight, expected weight for your height. And all of a sudden you're like, what is this apple shape?
Yeah.
One of the contributing factors I'm looking at is this whole flip in hormones. So it doesn't even have to necessarily do with your crappy diet or your lack of exercise or your, stress or whatever. Just the act of these hormones shifting seem to be contributing to the story.
Yeah. And think about what men look like and where men gain weight. Because we start to have a lot of the physiology start to be similar. It starts to be similar when we get to that phase, right?
Mm-hmm.
Where estrogen has dropped off. Testosterone will drop off too, but it lags behind the estrogen for years, right?
Yeah,
And
for a lot of women.
so then we start to adopt male physiology. And this is what we see borne out all the time, where estrogen is protective against cardiovascular disease, but then postmenopausal women have cardiovascular disease rates similar to men.
Yeah. Yeah.
Right? It's only
Yes.
when we're premenopausal that we have that protective effect. And then the same thing with women postmenopausal, they start to gain weight in their abdomen like men. Like you look at men and that's where they put their weight. And it's not that they have fat rolls. They don't. They have these big kind of bulging abdomens because of that visceral fat, that fat that's inside that's covering the internal organs. So it's interesting that we can actually see that borne out,
Yeah,
right? That's what we
absolutely.
see is happening.
And then the National Institutes of Health estimates 24% of people have fatty liver. I would argue it's a lot higher. And I say that just because liver biopsies are wildly invasive. But right now, as it stands, 24% of adults have fatty liver.
Oh
And
my
given that we
God.
know more than 90% of metabolic dysfunction and fatty liver can go with that and worsen that visceral fat, I mean, unfortunately, the cycle just goes round and round.
Are you ready for a breast cancer screening revolution? Well, I'm thrilled to introduce to you a breast cancer screening tool that I have only recently learned about, but I have universally adopted. This is the ARIA test. This groundbreaking at-home breast cancer screening test is one that I believe will completely change the game. So imagine a screening test that's as simple as shedding a tear, because that's ARIA. It's a non-invasive, convenient, and perfect for all bodies and all breasts. Dense breast implants, no problem. ARIA makes it clear for everyone, even women as young as 30. ARIA is backed by over a decade of clinical trials, thousands of samples, and it's developed alongside top breast health experts. Here's how it works. You collect a tear sample at home, and then ARIA then analyzes it for protein biomarkers that can signal early breast cancer. And the best part, you get a consultation with a breast health specialist to review your results. Now, ARIA isn't replacing breast imaging. I am using it alongside QT. It's complementing it and giving you a fuller picture of your breast health. Knowledge is power, and Aria is putting that power back in your hands. It's time to take control of your breast health, and Aria is another way of doing it. Go to aria.care, AURIA.care, and use my code DrJen20 in capitals, DRJENN20, to get 20% off. Back to our show. Hello, my beautiful listeners. I'm taking a quick break here to share something truly transformative with you today. If you're ready to take control of your breast health journey, then you need to get your hands on a copy of my book, The Smart Woman's Guide to Breast Cancer. I wrote this book to make a massive impact in the world of breast cancer, empowering women everywhere to make informed choices and educated decisions. You have so much more power and control over your health than you might think. And this book, this is a roadmap to harnessing that power. Inside, you'll uncover the truth about conventional treatments. They're often overestimated benefits and underestimated, underexplained, and underdisclosed long-term side effects. But more importantly, you'll discover the true drivers of health and how the choices you make at home every day can lead you to the best health, the breast health of your life, even after a breast cancer diagnosis. Whether you're looking to prevent a diagnosis, avoid recurrence, or simply live your healthiest life, this book is for you. Join me on this journey to empowerment and health. Grab your copy of The Smart Woman's Guide to Breast Cancer today, and let's revolutionize the way that we approach breast health together. We are not of the watch and wait school. We
Correct.
are of the, if your levels are not ideal, and we're looking for ideal levels, and I would love to hear what your ideal levels are. We talked about glucose. We talked about insulin. Glucose, you want a fasting glucose below 90.
Yep.
Insulin, you want a fasting insulin somewhere between 2 and 5.
That's what I say. 2 and 5, 2 and 6. Yeah. Yes.
A1C, you're looking for a number that's less than 5, I would guess.
Yep. 5 or less, ideally.
And then where are you in terms of the vitamin D score? Where do you like to see that number?
If I can, if we can get it somewhere in the like 50 to 70 range, 50 to 80 range, I would be thrilled.
Yeah. Yeah, me too. I mean, I go a little higher just because I live in the world of breast cancer. So I like people to have a little more reserve. And incidentally, I think the numbers are like 80% of people who are diagnosed at breast cancer are at the time of diagnosis profoundly vitamin D deficient.
Which I've read
Profoundly.
that so many times over through the many years, and I don't understand why that's not part of standard breast screening. If you go get a breast imaging, if you see your OB, like if you're concerned, immediately I feel vitamin D should be part of that story.
It's awful. It's absolutely
You
awful.
get a PAP, you get a vitamin D. You get a breast exam, you get a vitamin D. Like you get like Oprah, you get a vitamin D, you get a vitamin D.
Well, that's
Everybody
how
gets a
it
vitamin
should
D.
be. It's
Yeah.
certainly how it should be, right?
Yeah.
Okay. And then I do want to ask you about thyroid, and then I want to move on. What are
Yes.
you looking for in those thyroid numbers? Because that TSH range that
Mhm.
is called normal and is deemed acceptable by the, mainstream medicine is way too big for my liking. And I think there are so many women who are walking around with hypothyroidism, which
Yeah.
incidentally is a risk factor and linked to breast cancer, because
Yeah.
when your thyroid is dysfunctional, that is the center of your metabolic system. We
Yeah.
talked about metabolic health, and loss of metabolic health is a huge risk factor for breast cancer. And this is often where we see the start of this metabolic dysfunction. So what are your thyroid ideals?
So when somebody does a TSH, let's assume they're not on medication. They're just getting a screening TSH.
Yep.
I like them to be around the number 2. So that might be somewhere between 1.8 to sometimes, depending on the other numbers, up to 2.5. That is not the range. The range, depending on your lab, usually goes up to 4.5 or 5. But I'm a lot tighter than that. I want, again, like 1.8, let's say to 2.5, depending on the person.
Yeah.
If they're on medication, your TSH might actually be quite a lot a bit lower than that. And that's different because of the medication. Now I'm more focused on T4 and T3. I'm not quite as focused on TSH. If your TSH is going up, I evaluate that. But if it's down, if you're if you're like, gosh, I'm on medication and my last TSH was 1. Okay, what are your T4 and your T3 levels?
Yeah.
Now your free T4, I want around 1. Ideally higher than 1. So if you're 1 up to, 1.4, 1.5, great. Your T3, free T3, I want around the number 3, but ideally higher. So 3, 3.1, 3.3. That's
Yeah.
about what I go up to.
Yeah. And
Yesterday I
mine are
consulted on a
very
case.
similar.
Okay. Yesterday I consulted on a case and their free T3 was 2.2 and 2 is the cutoff at this particular lab. And they had all the symptoms that you said earlier: dry hair, dry
Yeah.
skin,
She
missing their
feels awful.
eyebrows.
She feels
Horrible.
awful.
Horrible. And
Yeah.
of course she was, everything's fine, you're fine. I said, your power pack, your T3 in the cells is struggling. We need to get we need to figure out why. What's going on?
Yeah. Yeah, exactly. Absolutely. Exactly. So let's talk about this woman a little bit, because this woman is told that her labs are normal and she knows that she feels far from normal. So what are the functional tests? Like, obviously, you're going to do a complete panel because our mainstream medical, they are missing the patterns of dysfunction. They're not recognizing the patterns of dysfunction. It's not their fault. They're not taught to. But what are the functional tests that you then start to incorporate to help people to get to the why? Because we can easily prove that they have thyroid dysfunction. What next?
Yes, absolutely. So it's generally other parts of the body that we're looking at. So saliva testing, urine testing, stool testing as examples to help us dig deeper. Now, when we're looking at hormones itself, and trying to get more advanced, we talked about cortisol earlier as an option. I'm either looking at a urine test or some people do a saliva test. And the reason is that when you're looking at cortisol, and you mentioned circadian rhythm, a circadian rhythm is your cortisol goes up in the morning to a natural, it goes up to a normal high and drops down at night so you can sleep. That is the circadian rhythm. And then melatonin comes out. So melatonin's higher at night and drops down in the morning. And that's your rhythm. If your cortisol is too low, you may wake up tired, you're hitting that snooze, you're going for caffeine all the time. If your cortisol is high at night, you can't sleep, you can't fall asleep, you can't stay asleep, you feel anxious, you're spinning, you're jittery, all the things. So I want to see this rhythm, but we don't want your blood drawn 4 times in the day. That sounds awful. So now we can do saliva testing 4 times in the day. We can do urine testing where you basically urinate on a strip of paper, let it dry 4 times in the day, and now I can see the rhythm. With that, in addition, with urine testing specifically, we've known for a very long time that we can get other information out of urine testing. Back in the day, I'm sure some people have done a 24-hour urine. You collect your urine all day, all 24 hours. You put it in this big, ugly orange jug and then mail some of it off and you
I
get
have one of them right here.
information. That became cumbersome. So some labs have said, I think we can accomplish this by splitting it 4 times in the day and just evaluating those 4 pieces. It's close enough to a 24-hour. The reason urine is so helpful is it gets what's called a metabolite. And metabolite is a fancy word for the breakdown product of. You make estrogen. Where does it go? How does it break down in your body and come out the other end? Because not all ways and pathways that estrogen breaks down is ideal. You make testosterone. It breaks down. Where does it go? Not all those pathways are great. Some of the pathways encourage hair loss and cystic acne and anger and irritation, and other pathways don't. So it's nice to have these metabolite pathways to see extra information about your hormones. I like to know what your estrogen is, like in a blood test we mentioned earlier, but also where does it go? Because as you talk about all the time, breast cancer prevention, some of those pathways do have increased risk, let's say, for
Yeah.
potential
Yeah.
cancer
Because
formation.
some of those pathways are very unstable molecules
Yeah.
that damage DNA,
And
right?
we don't
And
want
that
that.
is kind of setting the stage. This cellular damage is setting the stage for cancer.
Yeah. And you can't get that in blood work, unfortunately. We're not there yet. We have to do it in urine. And then we have stool testing. Stool testing is to give us a snapshot, some insight into your GI tract, your gut health, which plays a role in your whole body. Inflammation, how you are or aren't digesting things, absorbing things. In women, the decline of estrogen and progesterone going through menopause greatly impacts our GI tract. We're at a higher risk for gas and bloating and constipation and heartburn. We're at a higher risk for what's called leaky gut. We're at a higher risk for increased inflammation because of this. So sometimes having this extra information, plus, my goodness, if you've picked up a parasite or candida or an amoeba, like I'd like to know this about you so we can address it.
Yeah.
So depending on your symptoms, history, where you've been, we have a lot of really cool options for extra functional testing.
Yeah. So I would love to know, are there any functional tests that you are running on everyone? Like is there any go-to for you?
So depending on the person, my go-to urine is called the Dutch test by Precision Analytical. And or I will do, especially if that they're very symptomatic, I will choose a stool test. I'll have them poop in a cup for science for evaluation. Sometimes I'll do both. Sometimes I will just start with the stool test. If a woman comes, she has all sorts of GI issues. Yes, of course she has hormone issues, but GI is really dominating. I will start with the GI because I know, like it starts in the gut, and let's focus on the gut. And oftentimes as we improve the gut, the rest of the body gets a lot better. Maybe not 100%, but significant percent. Other women are like, nope, I have no GI symptoms, nothing. My stools are like clockwork. I have no heartburn, no issue, but my hormones are a trash mess. I'm like, all right, we're going for the Dutch test. I want to see all your metabolite pathways. I want to see your cortisol through the day. I want to get all this extra information. I want to dig deep.
So you've brought up the Dutch test twice. This is probably the most common question that I get.
Yeah.
So I get, do I need a Dutch? Right? This is like my Instagram is filled with, do I need a Dutch? So can we dig deep into the Dutch test and talk about what it is, what it does, what you learn from it? And I would love it if it could include a little talk about the organic acids, which
Yes,
are also included in the Dutch test. What does
for
that
sure.
mean? What do we learn?
All the things. So first of all, Dutch does not test for Dutch ethnicity or genetics.
Oh,
It's
that's such a good
it's an
point.
acronym. It is an acronym. It stands for Dried Urine Test for Comprehensive Hormones. Heavy emphasis on the comprehensive. And it is an at-home collection test. You literally are given what are like thick filter paper cards. You urinate on them 4 times in the day, on waking, 2 hours later, around dinner, and before bed. You let the cards fully dry and you mail them off to the lab. Does everyone need a Dutch test? Of course not. But do I run the Dutch test on a lot of people because of how comprehensive it is? Yes, because the people who find me are saying, I don't feel well. I've already been to the doctor. I've been told everything's fine. I have a comprehensive history, a complex history of a lot going on. I'm like, well, we need a test to match that. With the Dutch test, like I said, you will get information about your estrogens, your progesterone, your testosterone, your cortisol, but you get that next layer down. I get to see where your testosterone's going. Are you converting it into the downstream metabolites, we call them, that cause the hair loss, the acne, the PCOS, the anger, the irritation? Because guess what? I have diet and stress reduction techniques and supplements and even medications that can help flip that. I can look at estrogen and see where you're going. It gives me insights into what we call your estrogen detox or estrogen metabolism. So estrogen goes through phase 1, it can go through phase 2, and then it gets excreted out of the body. I want to make sure it's not going
Hopefully.
down hopefully the DNA damaging pathway that you mentioned. So, and guess what? We can use diet choices. We can use some supplements to help. We can use some lifestyle factors to mitigate this. Like, how fun is that? I
Yeah.
can look at the progesterone and see how your progesterone kind of breaks down. And for some women who struggle with sleep and anxiety and irritation and irritability, it's possible when their progesterone breaks down, they're breaking down what's called the beta pathway, which doesn't really help that. But if you break down the alpha pathway, you're less likely to be anxious. You tend to have better sleep. Or I know if I'm going to put you on progesterone, that I need to put you on enough that we can at least support the alpha pathway. So I just get really cool information even on how to work with your hormone therapy if that's the option route you go. And then you mentioned organic acids. Organic acids give us insight, the ones on the Dutch test, they give us insights into certain nutrients. So we have insights into vitamin B12, which I mentioned earlier, B6, glutathione, which is one of your most potent antioxidants, melatonin, which is one of your other most potent antioxidants and very important for sleep. We think of melatonin only for sleep, but remember melatonin's been around billions of years. That's with a B. As the car commercial says, like melatonin knows a thing or two because she's seen a thing or two with billions of years, but she's in almost every cell of the body. Like your mitochondria love melatonin. She's super potent and helpful to just killing things off that aren't supposed to be there. So Dutch gives you insight into your melatonin. And then it looks at some other markers. It looks at a biotin marker and it looks at a marker for your gut health. It's called indican. If your indican is elevated, it gives me already like a screening marker of, ruh-roh, like we need to be looking at your GI tract. This isn't good. Indican increases with what we call, it sounds gross, putrefaction, where you're not breaking your food down
Yeah.
and it's stagnant and it's spilling over and it shows up in the urine. So we can see really cool markers on that. And then I tie it all together. Like, oh, this vitamin impacts this estrogen pathway. Oh, this impacts the testosterone. Oh, here's why your cortisol may or may not be following the correct pattern. So we get all this really cool insight. Even in the cortisol, people don't even believe this. The cortisol pattern on the Dutch test, there are certain patterns that can indicate to me that you have a thyroid problem. So let's say you run a Dutch test and you have a particular, I can go, oh, have you had your thyroid tested in a while, specifically your T3? Because it's showing up, you might have an issue here. So it can even point me in other directions if you haven't had that tested yet. So it's pretty comprehensive.
Um, I want to know what is the physiology behind, why do you look at a biotin on the Dutch test?
Well, a lot of it, biotin, believe it or not, of course, we know of hair, skin, and nails.
Yeah,
But
that's what
biotin,
everyone thinks of
that's
it
what
for. So
everyone
that's
thinks.
why I
But
wanted you to talk about it.
biotin is also helpful for breaking down carbohydrates in proteins. So we do need biotin for more than just hair, skin, and nails. So if you do have metabolic dysfunction and you're kind of a carb addict, you may find that you need more biotin than the average person.
Um, we know that the what happens in our gut ends up really being important in dictating our health, that 70 to 80% of our immune system is housed in the gut. And our biggest exposure to the outside world is through what we eat and what we drink. And through what we eat and what we drink, that has a big effect on our microbiome, which are the organisms that we house in the gut. I mean, they're everywhere in every contact with the
Yep.
outside world on every surface, but the majority of our microbiome is in our gut. And the health of our microbiome usually dictates the health of our immune system, so on and so forth. So I I routinely use gut testing
Mhm.
to evaluate people where they are, what they need, even if they don't have GI symptoms. It's kind of my go-to start. I'm curious as to what you do about gut microbiome testing, how often you use it, what is your go-to test, and
Mm.
what do you like about that test?
I do microbiome testing all the time, or I could say when I was in full-time practice, I did microbiome testing all the time. I consult on a lot of microbiome testing. There are some big companies out there for microbiome testing. I'm curious which one you use, but the big ones, one is called DSL, it's the GI map. One is called Genova. Another company is Doctor's Data. And a fourth one that I really like is Vitrac, Vitract. And obviously, I've guinea pigged myself on all of them and worked with all of them. I'm curious what your favorite one is.
So for years, I used the GI map, and I
Mhm.
still really like the GI map because I think it is not so overwhelming for
Yeah.
both patient and provider. I think you get a lot of good information there. Is it the most comprehensive test? Absolutely not. I have used the GI effects in the past. That's more comprehensive than the GI map. Currently, I'm using the Zoomer.
Oh, yeah. Forgot about the Zoomer. Yeah. I've never done a Zoomer. I think that's why I forgot about it.
Oh, you should do a Zoomer.
I should
I
do a Zoomer.
recently did a Zoomer. And, you know, more isn't always better.
Mhm.
And so I may fall back on the GI map again. I'm not certain yet.
Mhm.
But right now I'm in the season of the Zoomer.
I, in practice for years, because GI map didn't exist back when I started practice, I did Genova. There was what was called a CDSA, Comprehensive Stool
Now
Digestive
it's called a
Analysis.
GI effects, I
It's
think.
called something 360, I think. Genova's going to listen to this and go, "How did you get it wrong?"
Oh,
But I actually have a doctor's data kit right here to do, which is quite good. They have excellent feedback. And I just recently, within the last year, did a Vitrac, which is very fascinating in the way that they do their stool test as well. So is honestly, a lot of them run the same things.
yeah.
Their science, their methodology may be different. So if you're a practitioner listening, like you got to be aware what their methodology is. There are a few key pieces I look for, like the inflammation pieces. I look for the estrogen piece called beta glucuronidase. And actually, it's not just estrogen, it affects progesterone, it affects testosterone, it affects all your hormones.
Yeah.
Often they run gluten markers in there. I look at kind of like your like a soldier, like how many soldiers you have down there. It's called secretory IgA. So as long as like we've got some key pieces, that I make sure I look at every time, um, and it's a reputable company, I'm familiar with using it.
Yeah, I agree. And I would, if you could recall, I would love to hear just your experience where you had a patient whose functional testing really made a difference in their course. That um, that what you learned from their functional testing really dictated what would happen with them and was kind of the key, the light bulb to what was happening and how you corrected it.
One that comes to mind was very recently where there was a woman who had all the key features of PCOS, polycystic ovary syndrome. She'd seen her OBGYN who did testosterone in blood work, ran a testosterone, and it was completely normal. And the OB said, well, it's not PCOS because your testosterone's normal, and that's a diagnostic criteria. You have to have high androgens and high androgenic symptoms. She had the symptoms. So she came to my group and we actually ran a Dutch test on her, and her testosterone was normal, but all the markers underneath, as testosterone can break down into what we call alpha or more androgenic markers, were all very in the red. So it was almost like a wolf in sheep's clothing, where the testosterone was a fake out. It was totally normal for whatever reason. But as it moved downstream, it just got more and more potent. And so I said, you have PCOS. And while your testosterone's not high, look, like these other markers are high. And this is why you have all this cystic acne and you're losing your hair and, experiencing these symptoms. And guess what? There's a lot we can do about it. Whereas she had been brushed off as, well, I don't know, good luck. Like, let's try Accutane for your acne and like, let's try some other stuff with these symptoms.
Yeah.
I said, it's androgenic. It's like, we can do something. And oh, by the way, we should look at your insulin, which is not a diagnostic criteria for PCOS, although everyone should have it run. And it was like 17 or 18, which of course is much too high for you or me. And that's very stimulatory to androgens that can increase the
Yep.
the hormone output of the ovaries. And so we just sort of pieced together as we went down this whole trail. And then on top of it, she had very dysfunctional cortisol. It was very elevated. She had a lot of very chronic stress and inflammation. And of course, cortisol. We love cortisol. We cannot get rid of cortisol. It's very important in our body. But of course, like anything, like Goldilocks and the Three Bears, too much, the soup bowl is too big and too hot, we have a problem. And she had that. And so all that cortisol was just worsening the problems. It was encouraging her weight gain, and she couldn't sleep. And she was just so grateful to have on paper, to see all this red. Everything was red. And she wasn't worried or scared at all. She was like, I have answers. I have answers
Yes.
that I haven't been able to get for years.
They're tremendously relieved.
Yes.
They're tremendously
Yes.
relieved when they have that piece of paper. And I suspect that you knew what you were going to find.
Oh, I did.
But isn't it
Yeah.
amazing that you can have a piece of paper that demonstrates all of this,
Yes.
right?
Absolutely. I mean,
Because
people
it's
put it on
so
the fridge.
yeah.
They're so, yes, they're so relieved. They're
Yes.
validated.
It's
you know?
validating. That's
Mhm.
exactly right. They feel validated. And probably for these women, it's the first time in a long time that they feel validated because they've been searching for answers that
Yeah.
weren't there before.
Yes. Yes. I
Now,
had a case recently with endometriosis, just quickly. So well, actually, I should back up. She had severe cramps since the dawn of her period, severe vomiting, lots of ibuprofen, took her out of school. She's now in her 20s. She was consulting. And I said, what had been the options? And she said, well, the birth control pill, which I didn't really want to do, tons of ibuprofen, which is awful, but I keep going back to my doctor and they're just like, yeah, that's what happens. Like women get bad cramps. And immediately, whenever I hear severe cramps since the start of your period, I'm like, has anyone worked you up for endometriosis? Has anyone looked at any of this? She's like, I don't even know what that means. No, of course not. So there's no lab test for endometriosis. I will start with that. But she also, because the organs are right on top of each other, she also had a lot of GI symptoms, a lot of gut inflammation, so to speak, a lot of gas and bloating, a lot of constipation.
yep, the neighbor's
Right,
upset.
their neighbors, the uterus, the intestine, everything's right there. And I said, all right, we're going to get you evaluated for endometriosis, and I'm going to have you do a stool test because I need to see what is growing or going on in your GI tract. And of course, sadly, as you can imagine, her GI test was a mess because between just her own GI, and then of course all the inflammation, she absolutely had endometriosis. She had exploratory surgery for sure. And I just thought, God, she's been dealing with this since she was like 14 or 15 years old. And I understand in puberty, things, can happen, or they just try to blame puberty, or they're like, well, let's see if it works itself out. And I'm like, nobody even thought this through. Like when she hit her mid 20s, nobody was like, geez, that's 10 years of severe 10 out of 10 cramps, living on ibuprofen. No one thought to look this up or evaluate it. Anyway, she's doing a whole lot better. We've been working super hard on our GI tract. It's really helping lower the inflammation. It's really helping her hormones. It's really helping her pain. She get her life back.
Yeah. Yeah. And just knowing that that's not normal.
Yeah.
It's not normal to suffer.
Mm-hmm.
It's just not normal to suffer. And usually we can find answers, right? We
Yeah.
can find answers. Okay. I have some rapid fire questions for you.
I love it. Let's do it.
Okay. Let's start off with coffee. What do you think? Are you a coffee girl? Are you a matcha girl? Or do you think that we should be staying away from both?
I'm not a coffee girl only because it makes my heart race so terribly. I'm a very slow breaker downer of coffee. So I personally can't drink coffee.
You're a poor caffeine metabolizer?
Yes, I am
Okay.
a poor caffeine metabolizer.
Do you also
However,
not do matcha?
I can do matcha. I can do green tea. I can do black tea. I do have to be careful with the amount, how many cups that I have. And that's my go-to. I usually, jasmine green tea is my absolute favorite, followed by Earl Grey.
Beautiful. Okay.
Yes. But I'm not opposed to coffee. There's some good research on coffee.
Yeah. What is your favorite lab marker? The one that makes you go, oh, that's interesting.
Um, my favorite lab marker. Honestly, and I mean this seriously, it's probably insulin
It's mine
because it's
too.
so infrequently run and yet it tells such a story. So when I
I
get it back and it's in the double digits, I'm like, oh, I knew
Yep.
it.
Yep. Totally agree with you. That's mine too. Okay.
Love it.
What is the one supplement that you never travel without?
Magnesium. I don't even have to think about it.
Yeah.
I, yes, I can tell immediately if I don't have my magnesium. People ask all the time, if you were on a desert island, what would you take? Magnesium. Obviously, I wouldn't take vitamin D because I'm assuming sun would be there and I would be out in the midday sun getting my UVB.
Yeah.
But I would take magnesium.
What's one wellness trend that you wish would go away already?
All the weird stuff people do with castor oil. And I love castor oil. I've been using castor oil since 1999. I'm such a big fan of it on the skin and is, just part of all the like liver support and things. But I have just seen on social media some weird trends on what young influencers are doing with castor oil. And I'm like, I don't think it works that way. Like, that's so interesting.
Ooh, do tell because I haven't seen any weird castor oil stories yet. What's a
The,
weird castor oil story?
to pour it in your belly button and put a band aid over it,
Oh, that is weird.
which I'm like, I love castor oil, but if you're going to use it, smear it. Like it needs to go from your rib cage, especially your right rib cage, all the way across. Like make it work. Cover the
Yeah,
abdomen, get the groin.
have it cover the abdomen because
Yeah,
yeah, I agree with you. I'm not sure that that's doing very much.
I would. And yes, I just have questions. Like,
Yeah.
yes.
Yeah. Okay. What's something about your own health journey that you think might surprise people?
My own health journey. One of the big ones, like if I had to go back and do it again, is I'm gluten free, and I've been gluten free for a very long time. And when I look back at my childhood and allergies and skin and acne and hair and energy and things, if my family had known to give up gluten, we tried dairy, but nobody went into the gluten part. Everything got better, exponentially better when I gave up gluten. And the longer I've been off of it, the better the better things have gotten over time. Skin allergies, my ability to eat dairy again, like all of these things just got so much better.
Hmm.
And it doesn't mean everybody has to give up gluten. Like I tested positive for it, and so I'm diligent. I am 100% gluten free at all times, and I think that has made a huge impact in how I'm in my late 40s now and how well I feel being almost 50, as I think going gluten free so long ago just cleaned everything up, really lowered my inflammatory load. My immune system worked so much better. I think everything just was better when I gave
Yeah.
up gluten.
Yeah. I agree with you. And I actually take it a step further because I think everyone's healthier without grains. Now, obviously,
Yeah.
the non gluten containing grains may be tolerated, but I think everyone gets healthier without grains. And grains, like we have no, as humans, we have no nutritional need for grains. And if we
Mhm.
never had another grain again, we would suffer no nutritional deficiencies. So I actually don't think that we should be consuming things that have no potential benefit for us. So
Mhm.
I advocate for a grain free diet. That's kind of the space that I live in. And everyone, even if you're not sensitive, everyone feels better
I've
when they
noticed
avoid
that as well.
grains.
I've noticed that as well.
It's
I don't eat
really,
a lot of grains in general, but I do eat some. And it depends, like I tend to alternate. I sort of rotate depending on my exercise schedule and
yeah.
where I'm in my
Yeah.
cycle, like things like
Well,
that. But I'm pretty low grain.
you're fortunate to be still young. So I was tolerating a little bit of grains when I was your age, but not so much anymore.
And I hear that a lot, and I think that needs to be discussed more often. Things we
Yeah.
could, like wine or alcohol. I wasn't a big drinker, but I remember my patients who were older than me say, you wait, you won't be able to tolerate that one celebratory glass anymore." And
Yeah.
dang, if they weren't right, I
Yeah.
don't drink because
My
my
trainer
liver
and
says
I,
no.
yeah, my trainer and I, who we've been friends a very, very, very long time, and we talk about like, during the days of when we were in our 30s, and
Yeah.
we
Yeah.
would have no problems going out and having wine at dinner and being fully functional the next day.
Yeah.
And, fast forward 20 years and we're not drinking wine at dinner anymore because
That's the
we
truth.
can't get up the next day. We can't think the next day. We can't move the next day. We can't be our high functioning selves the next day. And it's not worth it.
It's not, and I don't even sleep. Like the
Yeah.
hot flashes, the
Yeah. You
constant
don't sleep.
waking, the blood sugar roller coaster. Oh, it's so
Yeah.
not worth it.
It's not worth it.
Yeah.
Okay. So, what is your go to hormone supporting ritual? Like, what is something that you do to help support your hormonal health?
D, all of the things. I feel that I have, and I'm assuming you probably are very similar. I have a lot of just naturally built in parts of my day and what I eat, everything from my hydration to the vegetables to the fiber to the amount of protein that I get in a day, how I start and end my day. My middle of my day is obviously, like a lot of people, chaotic. So I start my day with my tea and my meditation, little meditation, journaling, just quiet time.
Mhm.
I end my day with my sleepy time tea or my holy basil tea. I read a real book in bed and wind down. My exercise routines, the friendships that I keep, my relationship. I do a lot. I'm very disciplined, but my husband always says, you're the most disciplined person I know. I'm like, no, there's more disciplined people out there than me, but I do it for a reason. I want to feel really good for the rest of my life.
Yeah.
My longevity friend I mentioned earlier, Dr. Eve Henry, she said, we're constantly negotiating against the four horsemen of aging, or horsewomen, but it's cardiometabolic disease. It's neurodegenerative disease. So like Alzheimer's,
Yeah.
it's frailty. So break a hip, osteoporosis, and then it's cancer. So I don't want any of those. And my family lives a very long time. I have longevity genetics regardless of what you do. And I would prefer to do it not in a wheelchair, not with a broken hip, not fatigued all the time, not weak. And so I actually incorporate a lot. And I've been doing it so long now that the discipline feels like my normal every day. It's
Yeah,
not a
it's your
burden.
routine.
It's
You've
it's
created
not too
habits.
much. It's my routine.
Yeah.
Yep. And I'm, 80 to 90% good on it most of the week.
So, if you weren't a hormone expert, if you weren't the functional medicine testing queen, what would you be instead?
I would be an Olympic equestrian rider.
Whoa.
Hmm. That's what I
Wow,
decided.
you eclipsed me. I would have been a
Oh,
wedding dress designer, but that's better.
that's cool too. I grew up in Kentucky, oddly enough. My formative years were in Kentucky, and rode horses, showed horses, was all in the horse industry, and then left for college and then moved to the West Coast. So got out of horses. But if I wasn't going to be a doctor and I could still be in the entire equestrian world, if I could wave a wand, that's what I would be. I would be
Oh,
known as an
wow.
Olympic equestrian rider.
Wow.
Why not?
Okay. Was there one book or podcast or something that changed your life?
Yes. Most recently in the last year, I read The Surrender Experiment by Michael Singer. It's a book that I feel has to find you or get you, or you have to hear it or be ready to read it. And surrendering is something I needed to work on because I am a firstborn type A controlling disciplined person. And to read that book was so helpful for me and my nervous system in just releasing, letting go. So it's not so much a health book, but from if you can identify as somebody has told you, like, you need to relax, control more, you need to surrender more, you need to trust more. It's a great read about that.
Wow. I'm picking it up. I just put it on my Amazon. I put it in my Amazon cart.
I love it.
Okay. My last question for you. If you had a billboard that every woman could see, what would it say?
Actually, you can't see it my screen, but I have it over there. It's called Healing Happens at Joy. Because
Oh, that's so good.
when we think of the vibrations, our vibrational level, way at the bottom, we have anger and fear and jealousy. And at the top, we have joy. Well, allegedly, apparently, the vibration of healing starts at the vibration of joy. And I find a lot of people are missing joy in their life. They're going through the routines, they're checking off the boxes, they're struggling with their health, but they're not looking around or finding or seeking out or appreciating joy. And joy is different than happiness. Happiness is kind of external. Joy is that internal, like warm you to your core, fill up the bucket type of thing. So healing happens at joy.
Oh my God. So I don't know if you know this about me or have heard me tell this story, because right now, like, my mind is being blown when the universe has people who are vibrating on the same
Uh,
frequency when they put them together. So I talk about cancer as being the shift from going from the chemistry of joy to the chemistry of stress, because that's where cancer happens, in stress chemistry. And what we need to do when we get someone who has a cancer diagnosis and they are in stress chemistry is we need to figure out how to shift them to the chemistry of joy.
oh my gosh, I love that.
Mm-hmm.
Well,
Yeah.
now you can, the healing, the vibration for healing starts at the level of joy. I have
Wow.
this, there's all different. I have this card. It has like different levels of, anger, shame, and guilt and apathy are at the bottom, and then, then we move up: willingness, acceptance, reason, and then like joy, peace, and enlightenment. So we want to be up
Yes.
here.
Yes.
And
Amazing.
joy is like, can be the little things in life. Sometimes people think it needs to be all day. I'm like, no, it's hugging your
Mm-hmm.
cat or your dog or your kid. It's the
Mm-hmm.
funny meme your best friend sent you. It's like watching the daffodils bloom in the spring. Like
Mm.
can be very little accumulations through the day.
Yeah. Yeah. I believe it. Beautiful, beautiful. This has been amazing. I want two things from you. First, if for anyone who is watching, not listening, it won't help if you're just listening, but if you're watching, Dr. Jones has a gorgeous painting behind her, like
Thank you.
gorgeous. So I don't know if you can shout out to the artist, or maybe if you can't remember her name, then we will
Yes.
put her name in the show notes, because the painting is just beautiful.
Her
Absolutely
name,
beautiful.
I literally just had to look her up online. It's Amira, Amir Rahim, Rahim, Amira Rahim.
Beautiful.
Yes,
Absolutely
I
beautiful.
found her on Instagram. This came for sale, and I said yes.
Yeah. Love it. Okay. And where can people find you? Where can people learn more?
Yes, my website is drcarriejones.com. And of course, I am on Instagram at dr.carriejones, and YouTube, youtube.com/at Dr. Carrie Jones. But really, everything's on my website. You could just link out from there.
Amazing. Dr. Carrie Jones, it was so wonderful to be with you today. Thank you so much for sharing your gift, your enlightenment, your real true soul with my community, because this is information that needs to get out there. Women need to know what tools they need to empower themselves. And I know that medicine, it takes a long time to change. It takes a long time for mainstream medicine to catch up, right?
Yeah,
20
it
years,
does.
20
It
years.
does.
But we can all speed up the process as our own advocates. But the only way that that's going to happen is if we know. If we know what questions to ask, if we know what to ask for, and we kind of have to know the answers in advance, right? Like if they
Absolutely.
come back and say, well, you're normal, well, tell me what that means. Because I heard that it's not normal to
And I
have
don't feel
a
normal.
glucose of 100, and I don't feel normal, right?
Yeah,
So it's conversations like this that need to happen often so that women know. And women know to trust their instinct and to keep going, to keep asking the questions until they get the answers and the validation that they want, that they need, and that they deserve.
absolutely. Absolutely. Well, thank you for having me to talk about all things labs today.
Absolutely. And for all of you out there looking for answers, I hope that you get a copy of my book, The Smart Woman's Guide to Breast Cancer, because this isn't just about do you have breast cancer and do you need support on your breast cancer journey, but the truth is that we all need to know about how to promote our health. Health happens at home with the things that you do every day. And the Smart Woman's Guide to Breast Cancer is your key to your health journey. So please make sure that you pick up a copy for you, for your neighbor, for your mother, for your cousin, for your sister, for whoever, for your friend, for whoever has breasts and needs to know this story. And know that I will be back next week, same time, same place. It's Dr. Jen. Bye for now.